This presentation will be discussing hypercalcemia and hypocalcemia. By the end of the presentation, we hope that you can identify what hypercalcemia or hypocalcemia might look like on an EKG strip. We are going to start with talking about hypercalcemia. Our book mentions that hypercalcemia is categorized as excess serum calcium levels above the normal level of 4.25 to 5.25 milligrams per 100 milliliters. We found from the web of the electrocardiogram that hypercalcemia types can be divided into mild, moderate, and severe hypercalcemia, all based on the range of their calcium levels. You can find these specific ranges charted on this slide. The excess calcium shown in hypercalcemia can end up weakening the bones, creating kidney stones, and interfering with the normal functions of the heart and the brain. The conditions listed on this slide are common causes of hypercalcemia. We want to highlight a few of them. Hypercalcemia is most commonly the result of malignancy, so malignant tumor cancer, or hyperparathyroidism, which is an excess of parathyroid hormone in the bloodstream due to overactivity of one or more of the body's 4 parathyroid glands that will cause high levels of calcium in the blood. Hypercalcemia can also be caused due to immobilization because over time, bones that don't bear weight will release calcium into the blood. Lastly, we want to touch on vitamin D intoxication. The main consequence of vitamin D toxicity is a buildup of calcium in your blood, so that hypercalcemia, which can then cause poor appetite, nausea, and vomiting. Weakness, frequent urination, and kidney problems may also occur. Treatment of this would include the stopping of excessive vitamin D intake. So when we see hypercalcemia, do we see it as life-threatening? We found that if it becomes severe, that is when it can be life-threatening. It is also important to note that if digitalis is present in hypercalcemia, it may precipitate serious dysrhythmias. Hypercalcemia is not an electrical issue, so the EKG reading may not give information about the site of origin. The rate and regularity should be based off of the underlying rhythm and not affected by hypercalcemia. The P waves, PR interval, QRS complex should not show altered or changed. Our main focus would be examining the QT interval and the ST segment. The QT interval is inversely proportional to the serum calcium level. So with our increase in serum calcium levels within hypercalcemia, we will see that the QT interval is shortened. The ST segment will also be shortened, secondary to the QT interval. It is important to mention that with marked hypercalcemia, the ST segment can even be absent, where we will see the T wave take off right from the end of the QRS complex. With this severe hypercalcemia, we will see what is called Osborn waves. These are a positive deflection at the J point. We will take a look at an example of these Osborn waves on the next slide. Other EKG reflections can include that severe hypercalcemia can mimic a myocardial infarction by having an elevated ST segment. Hypercalcemia is not usually found in cardiac arrhythmias, but sudden death during hyperparathyroid crisis and other conditions associated with severe hypercalcemia have been seen to be caused by ventricular fibrillation. If this is the case, you can see symptoms like palpitations and fainting. Lastly, second or third degree AV blocks may be present within severe hypercalcemia. Again, these other EKG reflections are worth noting, but they are pretty rare. This example of hypercalcemia is showing an Osborn wave, which is rare, but can potentially show in severe hypercalcemia. This image shows that there is a positive deflection at the J point. So once that QRS complex returns to the isokinetic line, we will see an immediate positive deflection.
Now we're going to do an explanation of that short QT interval. So some background information before we begin. Almost 99% of calcium is stored in the bone, 1% in the extracellular fluid, 0.1% in the intracellular fluid. 50% of total calcium is in plasma, and this is in the ionized form, which is the form that has biological activity at cell membranes. If extracellular calcium concentration changes, it will affect the duration of the plateau of the action potential. If calcium concentrations are too low, we will see the duration of that plateau actually increase. If calcium concentrations become too high, like we see in hypercalcemia, we will see the duration of that plateau decrease or shorten. Plateau duration of the ventricular action potential determines the duration of that ST segment. So changes in calcium concentration affect the duration of that ST segment and thereby affects the duration of that QT interval. So in hypercalcemia, the effective conduction time is why we see that shortened or absent ST segment with the shortened QT interval. Next, we'll talk about clinical significance. So calcium in the blood plays an important role in our body. It controls blood clotting, transmission of nerve impulses, muscle contraction, and other metabolic activities. Although calcium plays such an important role, signs and symptoms can be non-existent to severe. Here are a few signs and symptoms. Nausea, polydipsia, or being abnormally thirsty. This occurs because of excess calcium in the blood causes the kidneys to work harder to filter that blood and can cause frequent urination and excessive thirst. Fatigue, muscle weakness, and bone pain. And this occurs because usually excess calcium comes from your bones, which will then cause them to weaken, resulting in that muscle weakness and bone pain. Restlessness, confusion, constipation, calcium stones or nephrocalcinosis, impaired kidney function, angina, and calcification of the heart valves. Confusion, fatigue, and restlessness occur because hypercalcemia interferes with the brain's function. And through a study, we found that excessive calcium intake may cause constipation, calcium stones, muscle weakness, and impaired kidney function. It is also noted that patients have a higher incidence of angina pectoris and calcification of the heart valves. So how do we treat hypercalcemia? According to an article we found on the web of electrocardiogram, the treatments are based on two criteria: the severity of symptoms and the underlying cause. There are then three classes: mild, moderate, and severe cases. In mild cases, treatment does not need to be immediate. However, there are some advisements: the need of adequate hydration, avoiding high calcium diets, avoiding thiazide diuretics because they increase the amount of water and salt lost through the urine, and avoiding the bed rest situation. The bed rest situation is being immobile for a very long period of time, and this causes the bone to begin to release calcium into the blood. Moderate cases may not require immediate treatment. However, an acute rise to mild or moderate hypercalcemia can cause gastrointestinal side effects, which then requires the same treatment as severe cases. Finally, in severe cases, the patient will be dehydrated and will require saline therapy, which is IV hydration. Calcium levels will be remarkably high and require urgency in treatment. So the immediate treatment would be the use of calcitonin, and this helps lower blood calcium levels. A long-term treatment is the use of calcitonin with biphosphonates. Biphosphonates increase the bone density and strength, and then this helps prevent excessive bone reabsorption. Denosumab can be used if the body is resistant to biphosphonates. So it's an alternative. The last resort is to put the person through dialysis. This is used for patients with malignancy-associated hypercalcemia. So this is hypercalcemia that's associated with malignant cancers, renal insufficiency, or heart failure because the hydration can't be safely administered to the individual. So here's our first EKG example. I'm going to give you a few seconds to kind of look it over and see what you can, and I will then explain what's going on. All right, so if you look at this, you can see in all leads there is a short QT, and you also can see Osborne waves presenting. And again, as a reminder, it is an increase of the J point. So once the QRS complex returns to the isokinetic line at that J point, we see an immediate positive deflection. So we can assume this person would probably have severe hypercalcemia. All right, so this is our second example of hypercalcemia. Once again, I'm just going to kind of give you a few seconds to look it over and observe any abnormalities. All right, so the first thing you're probably looking for are those Osborne waves once again. However, in this case, we're not actually seeing them, but we're still seeing that short QT if you look very, very closely. So that is telling us that it's probably not as severe of a case of hypercalcemia, but it's still probably maybe a mild or even moderate case.
Hypocalcemia is the shortage or below normal levels of serum calcium. Significant ECG changes that indicate hypocalcemia are seen in the ST segment and QT interval. The ST segments are prolonged and the QT intervals are also prolonged, but beyond the normal limits for heart rate. Common causes of hypocalcemia include chronic steatorrhea, diuretics, which can cause electrolyte imbalances such as hypocalcemia, hypomagnesemia, osteomalacia in adults, and rickets in children. Osteomalacia is the softening of bones, typically through the deficiency of vitamin D or calcium, and rickets is the softening and weakening of bones in children, usually due to inadequate vitamin D. Hypoparathyroidism, which is the state of decreased secretion or activity of the parathyroid hormone. This leads to the decreased levels of blood calcium and increased levels of blood phosphorus. Pregnancy and respiratory alkalosis and hyperventilation. Diagnostic characteristics. Notable changes in the ECG due to the electrolyte imbalance hypocalcemia are the QT interval and the ST segment. The other ECG characteristics, like the site of origin, the rate, the regularity, correspond to the underlying rhythm. With low serum calcium, you can expect a longer or prolonged QT interval and ST segment. It is rare, but hypocalcemia could potentially result in arrhythmias, such as torsades de pointes, ventricular tachycardia, or a complete heart block. It is important to first note, depending on the severity, hypocalcemia can present with no signs or symptoms. Even chronic hypocalcemia can be asymptomatic. But the signs and symptoms that would be present with hypocalcemia are neuromuscular irritability, such as twitching, cramping, carpal tunnel spasms, or tetany. Carpal tunnel spasms is the involuntary contraction of hands and feet, and tetany is very similar, as it is the intermittent muscular spasms or involuntary contractions. Hypocalcemia can potentially cause cataracts if left untreated, cardiomyopathy, and congestive heart failure. Patients may also feel weakness, fatigue, and a sense of depression. Treatments for hypocalcemia. For severe tetany, seizures, or altered mental status, intravenous calcium salts are used. Below is a link that you can click on to observe what tetany in a patient may present as. The goal of providing an IV of calcium salts is to control possible symptoms, increase calcium to normal range, and normalize the QT interval. Usually, a chronic oral regimen begins after the calcium serum is stabilized. It is important to note that calcium supplements are best taken divided up throughout the day and with meals to enhance absorption.
This is an example of hypocalcemia. If you take a look at leads V4 to V6, you will notice that there's a long QT interval, as well as if you looked at lead 1 and lead 2, this is also showing a long QT interval. This is another example of hypocalcemia. If you take a look at leads 2, lead 3, lead AVL, lead V2 and V3, you will notice that there is again a long QT interval.